Many professionals were never taught how to fully assess tongue tie, and families are often left trying to reach their breastfeeding goals without the support they actually need. If feeding feels harder than it should, I don't want you to be alone. I wrote Tongue Tie for Parents to help you understand what's happening and how to move forward with a clear, thoughtful approach. It's the same guidance I would give you if you were sitting with me in my office. It takes a holistic, functional view, guiding you through what to look for, how to think about next steps, and what actually helps. Available now on Amazon. Link is in the show notes. Welcome to the Tongue Tie Experts podcast. I'm Lisa Palladino, a registered nurse, midwife, and lactation consultant with over 35 years of experience, and I'm grateful that you're listening today. This podcast is for families impacted by tongue and lip ties and for the professionals who care for them. Whether you're a parent looking for answers or a professional who knows there is more to learn than what many of us were taught in school, you are welcome here. I hope each episode helps you feel a little more informed, a little more grounded, and a little less alone. My own clinical work is centered on infants and breastfeeding, but these conversations often reach beyond infancy because function matters at every age. Together, we'll talk about tongue tie, lip tie, all stages of feeding, oral function, airway, and how we can support families with more clarity, confidence, and compassion. I'm so glad you're here. Let's get into today's episode. Hi, everyone. I am your host, Lisa Palladino. Welcome back to the Tongue Tie Experts podcast. Today, I have Jess Draper with me. Jess is a holistic infant occupational therapist, IBCLC, and pelvic floor therapist. I love that combination of OT and IBCLC. And she's based in Eugene, Oregon. Through her practice, Hali'a Therapeutics, she provides a concierge-style care for families from pregnancy through the first year of life. Jess brings a whole body nervous system informed lens to infant feeding, oral motor function, movement, milestones, and tongue tie care. Her work supports both baby and birthing parents as a connected dyad with an emphasis on regulation. Hi, Jess. Thank you so much for being here.
Hi, thanks so much for having me.
It's great to chat with you. We met briefly at the ICAP conference, and I'm interviewing so many people. Anybody listening, like in these next couple of months, are going to be saying, "But did Lisa talk to anybody on the podcast that she didn't meet at ICAP?" Because
it was such a
going
good
on. And unfortunately, when you were presenting, I had to keep jumping back and forth because very good friends of mine were presenting at the same time, and I was so frustrated because I wanted to hear both of you. But yeah, so now we get to dive.
That was the hardest part about ICAP was I wanted to be at every single presentation, but there were so many good ones that we had to separate.
And I figured I'd start with that full disclosure that I didn't see. And that's more, that like motivated more to want to have this conversation with you because I heard highlights from what you spoke about, and I'm going to watch the recording. But I said, let me get it straight from Jess's mouth first. So here we are. Thank you.
About it.
So Jess, tell me about how does someone who's an OT get into this work? Because you could have gone in so many directions as an OT, right?
Oh my goodness. Yes. And I did. I think that was like what drew me to OT was we could be so applicable to so many different stages of life and so many different areas of helping people. But like the main thing that we always come back to is function. And I loved being able to like actually help people accomplish a goal or even just like get through their day. Right. So I kind of jumped around a little bit. I started out with kids and then I went to adults and then I worked at a trauma hospital where I worked with both kids and adults. And then really kind of shifted my focus towards feeding and solely kind of narrowing down to infants after my 3-year-old was born because she really started to kind of progress beyond just normal feeding patterns and really
Hmm.
started to get me more into the lactation world.
Yeah, it's pretty incredible how many professionals I speak to who have entered this world because of their experience with their own children. And that only talks more, points to the fact that we don't really learn about this in school. And so many providers can't help us with our own children, or in my case, grandchildren. So it sends you down rabbit holes of learning, right?
Yeah, I had an amazing IBCLC in my area who would came and did home visits and really helped us and identified her tongue tie and all of those things. But even she was like, she kind of planted the seed early on and was like, we need an OT here. We need an OT. And every visit she would say that, like,
Hmm.
come do this. And I
Right.
think, she was a really good inspiration and just has been an amazing mentor for me
Hmm.
throughout the whole process. But it was that piece of my daughter where I was like, these kids have so much neuroplasticity, but instead of us treating the actual like root cause, what's actually happening, rehabbing the tongue function, every other provider in the rehab world that I was going to were like, just give her prunes, just give her. I'm like, she is too young to be doing
Right.
prune puree at 2 months old. Like,
Right.
there's
Right.
something else
Right.
happening.
Yeah. So the OT that is on my team, because I'm so fortunate right now to have, grown a team over the years in my fairly local area. And she was my patient for lactation. And at the time, she was taking care of school age kids and she was working in the schools. And I like to take a little credit for like pushing her the way your IBCLC pushed you. I kept pushing her and pushing her. And now she has a space with she's an OT and she's got CST training, and she has a space with a SLP who has CST training, and they're doing all kinds of wonderful like tummy time
Amazing.
classes and mommy and bean things, and it's just a lovely, lovely space and such a great collaboration. And I'm just so grateful. So I didn't know anything about occupational therapy until I met this woman. I
Oh,
just
how
thought it
great.
was like I worked in the hospital as a nurse, and I thought the OT was the person that comes in and help the people after the stroke, like learn to use their hands again. Like that's all I
Yeah.
knew about OTs. And that was such a shame that, I didn't know what I didn't know about your field. So,
I mean, it's such a hard field because it is so broad and it's so patient focused. It's really
mhm,
hard to describe it. Like, most people know us as the one thing that we do whenever they had that experience. So, like, dad had a stroke, or
mhm.
maybe your child has autism, and so you only know us in the pediatric. Like, it just, it's too broad to even
Yeah,
jump
yeah.
into.
I mean, the same with nursing, right? As a nurse, there's so many different things you could do, so many directions you can go in. And even as a midwife, I've gone from catching babies and doing GYN to functional medicine without even, virtual work and,
Yeah.
of course, lactation care and all that. So there's so many different, this, like, sometimes I want to just clone myself and be all the things, but gotta
Right.
see.
That
Yeah.
definitely is tempting all the time.
Yeah, 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 yeah. So one of the things before we signed on, we said we were going to talk about sensory processing, and that term gets thrown around a lot. I'd love for you to explain it to those of us who don't exactly know what you mean. What does a professional mean when they say sensory processing? And
Yeah.
how does that relate to the babies that we treat?
Sure. Yeah. So I would say the biggest thing with sensory processing is a very broad and complex topic as well. So there are lots of little nuances. So to just kind of bring it down to something that's attainable for a quick
Mhm.
podcast, sensory processing is really how we move and interpret and interact with our world. So we're thinking smells, we're thinking touch, and not just touch as a whole, but is it light touch where it's just kind of um, stroking the receptors that are on our skin, or is it that deep calming touch that's more going into those joints or muscles? And then we also have our hearing, which is what most people are familiar with, but we also have our vestibular system, which is inside our inner ear and controls how we maintain our balance and stay upright, and also how we don't get motion sickness, or maybe we
Yeah.
do get motion sickness.
Yeah, yeah.
So
So
it's
it's
our
very
body's ability to,
individualized, right? The way we
yes.
process things is individualized.
Absolutely. And how our body was able to develop at this young age. And what the biggest piece of sensory processing is, we want to look at how our body actually takes all the sensory information in at once, filters out what's important, and responds to it. That's the
Mm-hmm.
biggest piece with our babies for feeding, is if they're
Mm-hmm.
having a harder time quieting noises, maybe they're really auditory hypersensitivity, so they respond very intensely to maybe even just the smallest noise,
Mm-hmm.
then we need them to be able to learn to filter that out so that they can focus on feeding. Otherwise,
Mm-hmm.
every time a toilet flushes in 3 rooms over, they're like popping off the breast trying to
Right.
um,
Right.
look at find
And,
where that
and
noise
this
is coming
can
from.
be carried into adulthood, right? I mean, that's not really a,
Absolutely.
because my kids tease me that I have like an audio sensory processing because I can't handle when there's like low lying some kind of noise. Like I want to, if there's a song on, I want to hear the music. If it's like
Yeah.
muted, I'm like it makes me nervous. Does that make sense? Like
Yeah.
is that yeah.
Yes,
Yeah. And
absolutely.
like
It
I
makes
don't
you
like a lot of noise, got like noisy places make me nervous, you know. So I don't know where
yes.
that comes from. Maybe my mother like locked me in a room by myself.
You just had random noises coming at you as a
Yeah,
baby.
I don't know, but yeah,
Yeah.
so other things that we see with babies are like being very reactive, right? Like
Yes.
jumpy kind of.
So yeah, jumpy. So that would also be that sometimes is an auditory hypersensitivity, right? If you hear a noise and you see that baby that just has that overactive startle response
Uh-huh.
all the time, either
Uh-huh.
to noise or sometimes it's touch. In our babies with
Right.
tongue ties, we often see more of an overactive response to input to the mouth or an underactive response. So we have our
Mhm.
super gaggy babies that
Mhm.
anytime something enters their mouth, they perceive that as a threat. Um, and then we also have our babies where there's a nipple in their mouth and you cannot get them to start to coordinate movement or latch on at all because they don't perceive that that nipple is even there.
Mhm.
So definitely
Interesting.
that's our tactile system,
Right.
um, where we're perceiving that input.
Yeah. So when my grandson, he's outgrown it, he's 4. He didn't like anything on his arms. Like he couldn't have long sleeves. It bothered him. You know, you could
Mm-hmm.
touch him. He had no problem with that, but sleeves had to, you know, you couldn't push up his sleeves so he could like eat without getting dirty. You know what I mean? Like so he
Yes.
just they
Yep.
needed to not be tight on him. It would make him nervous. So that's another sensory processing issue, right?
Yes, and that's very similar to it is that tactile system, right? So when we're talking about just the top layer of the skin, or even those hair follicles being stimulated from brushing up the sleeves, it's very different than, like you said, you could still touch them. And some
Mhm.
people have a hard time being like, "But I don't understand. Why is it this touch but not that?"
Right,
Well, it's
right.
because our tactile system, that one that sits on top of our skin, actually runs along the same tract in the spinal cord as our pain receptors.
Oh,
So for
okay.
people that are hypersensitive to that, to touch, a lot of the times it's their body is physically reacting. Their brain thinks that it's pain in some way. So we can reorient that and start to get them to process it a little bit better if we actually provide a deeper touch, because then we're going through a few different layers, getting down to the actual receptor sites that are in the muscles and in those joints. And that helps to
Mhm.
override that
Yeah.
pain.
Yeah, he's very
Pain
lucky
tracking.
that his mom understood what to do for him because I have to
Love
be
that.
honest, it was frustrating to me because I was like,
It
you
can
know,
be,
back
yeah.
in the day, if your kid wouldn't roll up their sleeves, you just say, well, tough and just do it, you know?
Yeah.
So,
Yeah.
but my
It
my
comes to
daughter
mind.
was like, Mom, it's not that big of a deal, you know?
It's
And
okay.
he
Yep.
has outgrown it. He's not in that space now. So I guess we just had
Yeah.
to let him go with it, you know, for a
It
bit.
takes many, many instances of allowing that nervous system to feel safe and regulated to that touch for their body to then remap and process it a little bit
Mhm.
easier. And that's why I really love bringing it into the infant space, because
Mhm.
if we can remap them early on, before they're 6 months old, even, or before they're even 3 months old, like whatever we can do, then we're setting them up for lifelong sensory processing readiness, which is just going to
Mhm.
help them interact and engage with their environment even more.
Mhm.
Um, So I love, especially, we think of like our vestibular system, which is the one that most people are think of when we think of like car sickness. Our body
Mm-hmm.
has to interpret where our body is moving in space and then also reorient using our visual system to say, hey, we're safe and we're in a good
Mm-hmm.
location here. You shouldn't be sick. But that's why you have the adage of like, if you're in the car, just sit in the front, right? And then stare
Right,
at the
right.
road because that gives you something to visually anchor to.
Right. That makes so
Um,
much sense. I have someone in my
yeah.
family who is car sick and she has to sit in the front. She's fine in the
Yep.
front. She's
And
fine, borderline fine, she says, but
yeah,
she can't sit in the
she
back.
functions.
Yeah, she
Well, and then it's
functions.
the opposite. We have our kiddos who you'll see on the playground, they like are swinging, they're twisting that swing 1,000 times so that they can then let go and really
Mhm.
get lots of rotary movement, which is
Mhm.
more of that excitatory response. So they might not even perceive any sort of like little back and forth movement in their system. So they need that rotary to help excite them and turn on those postural muscles.
Oh, wow, that's interesting too. So
Yeah.
what would we see in a newborn? You mentioned like the mouth reflexes and not either hyper suck or unable to suck, hyper gag or unable to suck. What other things would we look for in a baby that would tell us that they needed help in that area?
Yeah, so many things. The popping on and off so I would say when it comes down to just feeding, a lot of the things that we see that are more sensory based rather than solely tongue tie based or solely lactation based is that it's unpredictable. Some days, baby or some feeds, they might start the feed and they're feeding really well. And then the next, they come off for a second, get distracted, come back on. And it's like, they have just lost all of their disorganization, and you're like, I've seen you have this skill, why is it not computing now, or why
Mhm.
does it only work in the morning and not in the afternoon? And that, I think, as IBCLCs is where it's challenging and at least fun for me to be able
Mhm.
to kind of go in and play detective and say, is it a flow issue, is
Mhm.
it a wakefulness, is it a reflex issue, like what's
Right,
happening
right.
here? But
Yeah, I
for me,
like
it's
to yeah, it's great that you said that. We often are detectives,
yeah.
and I just had a client the other day where we're trying to figure something out, and I'm like, well, do you use a different position at that time? What's going on in the house at that time? How do you feel? What's the difference? When does this one particular behavior happens? When is that? Once a day at the
Yes.
same time or whatever. So yeah, we are detectives in that. That's a great way to look at it.
Yeah, and so for those babies too, like you said, position change. So it makes me think of the babies who kind of have a hyperactive vestibular system. So any sort of movement they perceive as almost a threat or just it's overwhelming to their system. So
Mhm.
you think of when they have to switch breasts, they might feed really well on that first breast, but the second you try to bring them over to the other breast, they immediately are dysregulated and they like act not interested because they may
Mhm.
have even only gotten, half of what they should be expected to feed from the first breast. And so
Right.
you're like, I know you're hungry, but they're
Right.
satiated enough where they're not able to reorganize to get
Yeah,
to
and
that
that could
next
be
breath.
so confusing to the parent who is trying to figure out learning the skill of breastfeeding and saying, "Wait, I don't understand. Am I supposed to use both sides or not? Or what should I do? When do I?"
Or baby never wants the second side, but also they're not gaining weight.
Yeah, 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 yeah.
Hmm.
This is
Yeah.
bringing up this is bringing us scenarios that I've been in recently. So it's very nice,
Good.
and I'm sure our listeners are feeling the same way. Like, oh yeah, I remember that patient or the one I had yesterday, or
Yeah,
so the
absolutely.
word neuroplasticity came up, and let's talk about that. I think it's a
Yeah.
cool word, and
Yeah.
and as a person who is aging on that spectrum, I'm learning more about neuroplasticity and let that keep working for me. But we need to talk about that on an infant side. So tell me, what's the definition or a loose definition of
Ooh, loose
neuroplasticity?
definition, how I like to think of
Yes.
it.
Yeah, I know. This
It's
isn't like a test quiz. This is just
yeah.
well,
Like, "Ooh, it's been a while."
yeah, yeah, yeah,
No,
yeah.
but for neuroplasticity, especially in our babies and also aging adults, I mean, really, we have it throughout life long, but it's the way that our body can actually look at new tasks and adapt to make the neurons to be able to do that task.
Okay.
So, So in the babies, we're really thinking about that growth and those experiences. There's been studies or instances where they talk about children who were either severely abused or in orphanages where they were only ever in the dark, and their brain never learns vision because they were never
Mhm.
given those experiences to have to use their eyes, and
Mhm.
and so those never got strengthened. So when I
Mhm.
think of neuroplasticity, I think of all of the opportunities that we're giving our brain to interact with different things so that we can
Right.
actually create more brain growth and give
Right.
just more experiences to prepare, especially our littles, for later in life. But also on the aging side of things, when we're thinking of neuroplasticity, we're thinking of like, can I start brushing my teeth with my non dominant hand? Because that alone is challenging the brain. Or can we do
Mhm.
Sudoku or crossword puzzles? Like, what
Right,
other
right.
things
Yeah, yeah,
can
yeah.
we do to keep all those neurons
Yeah, or
firing? Because
learning
if
new
we don't lose
skills,
it, we,
right? Like learning a
yes.
new game or doing something differently. Yeah. So,
Languages, yeah.
yeah. So
And all,
so the neuroplasticity comes into effect when I'm just thinking that must have something to do with a baby who hasn't been able to move their tongue because they don't have full range of motion
mhm,
needs to learn how to move that tongue when it's
exactly.
released, right? So is that, am I
Absolutely.
relating that correctly?
Yeah, so there is also this other really cool phenomenon called mirror neurons in our brain. So even when they've looked at like functional brain scans of like amputees who have lost their limbs, or maybe they were born with a congenital limb loss, when they are looking at these functional MRIs, they are seeing that if they're watching someone clap or they're watching someone use their hand to cut with scissors, they are still having that area in the brain that should be responsible for moving the limb that's no longer there. It's
Oh,
still
wow.
firing. So they are actually getting that. So when we think about with babies and tongue ties, I like to think of the mirror neurons and the neuroplasticity as those moments when we tell parents like, "Hey, baby, is we're now working on rehab, right? So stick your tongue out at your baby and then
Right.
just wait. They'll mimic you, right?" So those are in real time, that neuroplasticity and that mirror neuron system activating to kind of expand the boundary of what they think their tongue is at that time.
Mhm.
Right? They think the tongue just goes up and down and helps when they're clamping, but
Right.
they don't realize that they can disassociate the jaw from the tongue
Right.
until we give them those opportunities to do
Wow.
that and show them on ourselves.
Right, right. That's really cool. And yeah, and my youngest granddaughter is just under 4 months, and she is doing that copying. Yeah. Oh, she's
Yes.
gorgeous, and she's so much fun. I love this snuggly age, right? And she's starting to
Yes.
laugh and coo
Oh,
and do all the things. And showed my son and his wife, watch, she can copy us, stick out her tongue, and she does, and they're like,
yes.
oh, she's so smart, like, yeah, she is.
Yes.
Babies are
Yeah, she
so smart.
is.
Babies are so
Yeah,
smart.
they are. They really are.
So
It's in
so
that
that
phase is that.
also, I do know a little girl who was born with malformed hand. One of her hands is malformed, or actually both of
Mhm.
them. And one, she has limited fingers, and I've seen her play with her friends, and it doesn't look like she's missing anything. She doesn't know what she's
Right.
missing, right? And it's
Yes.
incredible. It's incredible. And what you just explained makes sense for me. We think she's
Yeah.
got limitations, but she doesn't know she does.
Her brain is still working in the same way. And the
Yeah.
beauty of our brain is with that neuroplasticity, like it just figures it out, right? Like
Yeah.
you might not have three fingers, but you maybe have two fingers. And so you can still play piano somehow. And you watch people that can do that. And it's
Yeah.
amazing.
Yeah. I mean,
But
I saw
really,
her
it's like they
eating
were
with
a,
a fork and,
yes.
beautifully, beautifully
Yeah.
doing all the things, playing with toys, fighting with my grandson, like, being right
Yes.
in there with him and not having
And
a
I,
clue that she's different, which is
right.
beautiful.
It's
Beautiful.
so beautiful. And it's great when you have parents who have allowed kids to kind of expand those boundaries and not
Yes.
be limited by that, right?
Yes.
Because that
Yes.
shows that they really were affording her the opportunity to try things because
Yeah. Yeah,
that's how we learn.
she's a lucky little girl. She's got great parents.
Mhm.
So the other big topic, and this is one of my, I don't know, I don't want to say pet peeves, but ooh, it's head shape.
But
We
yes.
talk about head
Uh-huh.
shape, right? And
Yeah.
To me, there's different phases of head shape. We're all born a certain way, and we'll have a head
Yes.
shape based on many things that have to do with our gestation, our birth, our method of birth, and all that. And then there's head shape that can be malfunctioning as we grow, you know, based on what happens to us after we're out of the uterus, right?
Yeah, absolutely.
So both of those
Yeah.
things are concerning to me
Yeah, me
as a
too.
midwife and as a lactation consultant. So let's talk about head shape
Yes.
a little bit.
Well, the baby's bones, I mean, as you know, in the head are so malleable at birth, and they're made that way intentionally so that they can fit through the birth canal, so that they
Mhm.
can kind of reshape to actually come out. When a baby comes to me, one of the first things that I'm looking at before I even say is there not a tongue tie, I'm looking at their head shape, because
Right.
when we're thinking of the head forming, a lot of babies, particularly our preemies, and you got to meet my 5 month old preemie at conference, but
Mhm.
particularly our preemies or babies that are a little bit younger, or maybe they were stuck in a certain spot during their entire development of in the womb. Um, their heads will form to whatever pattern they were given. So if your baby was transverse or laying sideways, oftentimes we'll have one side of the head that maybe was buried more in the hip bone that gets a little flatter. And I think of like pumpkins on the pumpkin patch. If there's two pumpkins that are growing together, the sides that are touching each other as they expand tend to be flat. And so then when you
Mhm.
pick up that pumpkin, you're like, why is this one so beautiful on this side, but then this side is a lot flatter? Well, that
Mhm.
was the only available space for it to grow. And so um, we think of course, that's like the congenital side, right? Like they're born with it. But then once they're born, the other thing that comes into play a lot is how are they laying? Where is that pressure being put? Because the bones are so malleable that I think of them as a balloon. And if you put pressure on one side of the balloon, that side gets flat, but then the opposite side in that diagonal pattern tends to bow out a little bit too. And so that is us kind of shifting that pressure away from whatever spot. So most people think of just head shape as like plagiocephaly or one flat spot. But what we see in some of our preemie babies is they might have really good neck range of motion, but in the NICU they were flip flopped each way, which is great. But now they've created a head shape that is more what we call like dolichocephaly or scaphocephaly, where that head shape is really long and not really round. And in
Mhm.
those cases, you can't, I would argue, and I don't think I've ever seen a baby that has that style head shape that also has a nice, beautiful, wide palate, because
Mhm.
there is no way for that head to expand and be round. Um, with it, or I would say the palate to expand and be round within a head shape that is giving them the boundary that it has to be narrow.
Right. So I think that let me think before I say this. We have learned in silos, and we have disassociated the palate shape with the rest of the body, right? In our learning, right? So you and I are providers who are looking at both and all of it together. But sometimes you can go to a dentist and he's responsible for maybe the palate shape, maybe depending on the
Maybe.
dentist. And he's not looking at the shape of the head because that's for somebody else to look at, right?
Yes.
But it's so connected because how can you everything's connected in the skull. So how could those bones
Yes.
not be affected, not be moved by the way the head is shifting, right?
Right. If you have a wider skull base or a wider skull in general, then you have room for that floor of the mouth or floor of the sinuses to like
Mhm.
open up and actually give us more space there. Yeah, I agree. And that was the piece with my daughter where I was like, there's something happening. Like, what is going
Right,
on here?
right.
And we have those congenital forms, but then we also have like how our habits shape the way that our baby's head is growing too. So I've had
Mhm.
plenty of parents come to me and they have a flat spot and it's in like a funky position, but then as soon as I see them bottle feed, I'm like, "Oh yeah, there's the divots from your hand right there," because
Oh,
these babies
wow.
are feeding for 6 hours a day as a newborn on like the low end for some of our tricky babies. And if
Mm-hmm.
you're putting pressure in one spot for 6 hours in bones that are not fused, it just moves them. It's easy.
Right, right. And also positions for sleeping, and so much time in containers will affect. And
Yes.
that's my pet peeve. And
Hmm. And
not
those
letting
babies,
babies move,
right. And those babies,
right?
we tend to have the babies that are, in containers or in chairs, swings or something like that, where their head, if you look at the back of it, they have their neck and then they have their head shape that kind of peaks outward, right? Like they have the top of their skull is more angled outward than the bottom, and then they have like a really large slope, and that's because that's the way that the swing sits on them. So that's how their head
Mm-hmm.
grows.
Mm-hmm.
And when that happens, we tend to see that we don't get as much forward growth of the chin either. So then
Right,
when we're trying to get a deep latch, that just makes everything else that much
right.
harder.
Right. And there's a differentiation we have to make between what is the tongue restriction and what is the shape that we're, the palate shape, because of other factors that have nothing to do with the tongue. Because even if there is no tongue
Absolutely.
restriction, that head is going, flat head or misshapen head is going to affect the palate. So it's
Yes.
bi-directional, right?
Absolutely. And I think that's why sometimes it's frustrating for parents when they want to come in and they want you to say, like, our provider locally will not release unless you have someone who, if you're working with lactation and actually
Right.
have a thorough pre-plan and post rehab plan. So they'll come in and they'll be like, we just need the referral. And it's like, wait a second, there's all these things we have to actually like check and assess and make sure that
Right.
yes, baby may have a tongue tie and I might even be able to see it on that first visit and we'll talk about it, but we have to fix this before that is going to be
Right.
effective.
Right.
We've got to expand the head so that there's room for that palate to respond, because
Mm-hmm.
otherwise you have a tongue tie release but you still have such a vaulted palate that even if the tongue sits up there a little bit, it's not really going to change the shape too terribly much
Right.
until
Or
we
it
can get
might
good
not
contact.
have anything to sit against.
Exactly. Yeah.
Right? I've
There's
seen
nowhere
that.
for it to go. Hmm.
I've seen that more often than I like to
Yes.
say, and
Well, I
even one
know.
instance in my own family. But so,
Hmm.
yeah, and the other thing about head shape, that the in between, right? There's the what happens in utero, and then there's the birth process, which was what I was working with, and watching kids come out in unusually shaped heads that we know totally corresponded to the way they were either the few days or weeks before birth or as they came through, meaning they either were posterior where they were, facing the wrong way, sunny side up, or they were asynclitic, meaning coming down crookedly. And yeah, I
That
had
was my daughter.
yeah, my grandson had the most asynclitic molding that I ever saw, and such a high palate. It
Hmm.
scared me. I'm like, why my grandson? And I get accused of pathologizing my grandkids. So now he
It's
was
hard
my
not to.
first. Now I've stepped back and been like, all right, you call me when you need help. I won't stick my
Uh-huh.
fingers in his mouth, I promise. But yeah. So, but his palate is
Yep.
coming down. His head shape is good. He's very active. Everything's good because we followed up with good positioning and good
Yes.
exercising and some tools to help him use his. But if you come out with asynclitic molding and are always
Hmm.
kept in the same position, laying down, and are, not, if you have to bottle feed, you have to bottle feed. But if you're not breastfed, and that leads to different things in the shape
Yeah.
of. So yeah.
Well, yeah, and I mean, you think of even just the formation, like if I go back to transverse babies because it happens so often, but
Yeah.
if they're not able to actually like bring hands to midline in the womb and they're not
Hmm.
reaching across or using any of those
Also
reflexes for
twin
like,
gestation, right, where they may not
yes,
have the room for that mobility.
yeah,
Yeah.
absolutely.
Yeah.
They're and or just like parents that are smaller, like I'm only
Hmm.
4'9" and my
Right.
kids don't have a ton of room in there.
Right.
Um,
Right. Right. I got
so
two
you have
inches
to,
on you.
yeah. It always feels good when we're taller. I'm like,
Yeah.
finally.
Yeah.
Yeah. But
It's
I mean,
amazing that my kids came out. That's what my doctors were all like.
it's,
When I was pregnant the first time, and I think I've told this story before, I looked so big, right? Because
Mhm.
I'm 4'11" and I have a small frame, and my son turned out to be 7'10". Like, who would have thought?
Oh, wow.
And my doctor, who was my friend at the time, and back then I wasn't a midwife, I was an OB nurse. I didn't know anything about anything, really, because
Yeah.
you don't learn about this stuff when you're a nurse. You don't even
No.
learn about real birth when you're a nurse, which is a story for
Yeah.
another day. But my doctor said to me, you know what? Let's do an induction. I don't think it's going to work. You're probably going to have a C-section. And I was like terrified because I didn't really want a C-section. So I was like, all right, induce me. So I got
Yeah.
induced. Actually, his birthday is next week. He's going to be 35. And
Yay.
I did deliver vaginally. And he had pretty
Amazing.
much, he had a very, very big cone head, and he was 7'10", but I was so big and no one thought that this baby would fit.
Mhm.
So that's just the amazing, a story of how amazing our bodies are. And this happens every day if we let it, that babies will come out, right? And babies
Mhm.
may come out in funny positions and their heads may be molded awkwardly at first, but they do come out. And that's how we're
Yeah.
made and designed.
It's so true. Well, and a lot of my work too goes, I'm a pelvic floor therapist as well. And
So
so
that goes along
I
with it.
focus a
Yeah.
lot on birth prep. And we talk about that, like what positions can we use to help make sure that baby has more, or that your pelvis has more flexibility so the baby can
Mm-hmm.
actually get out symmetrically, right?
Mm-hmm.
Yeah.
Yeah.
I mean, there's so much that's all interconnected. It's hard not
Yeah.
to
Yeah.
jump into it.
Well, Jess, I feel like we could talk for like 3 hours,
Yeah.
but I don't want to keep you that long. Especially we're recording on a Friday afternoon, and I think both of us have a drop of Friday-itis. But
Yes,
this was
absolutely.
a wonderful conversation, and I look forward to continuing this another time, maybe being together at another conference, because I feel like we can learn so much from your information and your work. Thank you so much.
Thank you. I've learned so much from just listening to the podcasts that you put out there and all of your different work and publications too. So thank you for
Oh,
doing this.
thank
It's
you.
so
And
lovely to
yeah,
have as a
so
resource.
thank you. And where can people reach you? I'll put links in the show notes, but if somebody wants more information about the work you do or even your presentations that you offer, how can they reach you?
Yeah, probably the easiest spot is just on Instagram. I'm at Hali'a Therapeutics, so that's spelled Halia Therapeutics.
Okay.
I'm pretty active on there and can respond pretty quickly, or
Excellent.
you can send me an email, jess@haliaot.com.
Excellent. Thank you so much, Jess. Have a great weekend.
Thank you. You too. Bye.
Bye.
This podcast is meant for education and conversation only. It is not medical advice and does not replace formal education, professional training, or individualized care from a qualified healthcare provider. Always seek appropriate guidance for individual concerns. The views and opinions shared by our guests are their own and do not necessarily reflect those of the host or tongue tie experts. Many professionals were never taught how to fully assess tongue tie, and families are often left trying to reach their breastfeeding goals without the support they actually need. If feeding feels harder than it should, I don't want you to be alone. I wrote Tongue Tie for Parents to help you understand what's happening and how to move forward with a clear, thoughtful approach. It's the same guidance I would give you if you were sitting with me in my office. It takes a holistic, functional view, guiding you through what to look for, how to think about next steps, and what actually helps. Available now on Amazon. Link is in the show notes.